Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, a faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus. I'm also a family physician at the Gateway Family Health Clinic in Moose Lake. I'm your host for our program tonight on eye problems, cataracts, glaucoma, macular degeneration. The success of this program is very dependent upon you, the viewer. So please call in your questions tonight or send them by email to our address at pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Charlie Ahrens, an ophthalmologist with St. Luke's Eye Care, Miller Creek Medical Clinic, Hermantown, Dr. Todd Britton, ophthalmologist with Ralph Eye Care, specialist in Hermantown, and Dr. Joe Morehouse, an ophthalmologist with Essentia Health. Our medical students answering the phones tonight are Henry Larson of Spring Valley, Spring Valley, Wisconsin. As an old Wisconsinite, I'm already in trouble. Connor Mikolacek of Red Wing, Minnesota, and Joe Miller of St. Michael, Minnesota. And now on to tonight's program on eye problems, cataracts, glaucoma, macular degeneration. Please call in your questions. Gentlemen, it's great to be here this evening. Nice to be together again. This is always a good program. I think I'd kind of like to hear a little bit about your practices. So, Joe, can you tell us a little bit about your work?
Thank you. I work for Essentia Health. We have a group of 5 MDs and 6 optometrists. We have specialists in vitreoretinal surgery, pediatric ophthalmology, and cornea, as well as general ophthalmology. And then we have 6 optometrists who are wonderful physicians. And so yeah, we have a fairly broad-based practice. And I personally do general ophthalmology, a lot of cataract work, a fair amount of glaucoma work, and I treat some floaters as well.
Todd?
Yeah, so I'm Todd Britton. I'm a comprehensive ophthalmologist at Ralph Eye Care in Hermantown, Minnesota. And we specialize in cataract surgery, eyelid surgery, family eye care. We have 4 doctors currently working with us, 2 ophthalmologists and 2 optometrists. And I've been in practice here in Hermantown for approximately 5 years now.
And Dr. Ahrens, Charlie,
hi,
a little bit about your practice.
I work at St. Luke's at the Miller Creek Medical Clinic. Within the St. Luke system, we have 3 ophthalmologists and 1 optometrist. All of us are general ophthalmologists, and we run the gamut of basically almost all surgical and medical disorders of the eye. I myself am a general ophthalmologist like the other 2 here. Doing a lot of refractive cataract surgery, retina. We do a lot of medical retina, including injections. We have outreach clinics throughout the area as well, so I'm primarily at Miller Creek, and then I have an outreach up in Hibbing, so we can service the northern area of the state too with all of their needs.
Thank you all. It's just great to have that coverage. Todd, you brought the eye with you. Do you want to talk about the normal eye for us a little bit?
Absolutely. Yeah, I can go over some.
And you guys can fill it in where he goofs it up here.
And anyone can jump it at any time. So, but we will start with the model. So, I'd like to start at the front of the eye. So, we have the cornea, clear part of the eye, like the dome over the eye. If I remove this cornea, you'll be able to see the iris, that is the colored part of the eye, of course the pupil in the middle of the iris, which is the opening in the iris. Through that pupil, we can see the lens of the eye. And in this space lies a substance that we call vitreous. It's like the jelly within the eye. And you'll be able to see in the back of the eye the optic nerve, blood vessels radiating out to the back of the eye, and then of course the retina. Again, going back to the front of the eye, white part is the sclera, and attached to the sclera you can see the extraocular muscles.
Very good. Anything else you gentlemen want to add?
No.
Nice job. Good primer. Joe, cataracts. I think that's pretty common. as we get older, and we're all getting older. So
Very. Yes, cataracts can occur at any time of life, but of course they get almost universal once you've hit probably 55 to 60 years old. Your lenses are no longer crystal clear like they were when you were 12 years old, and the cloudiness of the lens begins to affect the vision. We worry about cataracts when they start to affect your lifestyle and affect your ability to visually do the things that you want to be able to do or need to be able to do.
all right, Charlie, let's talk a little bit about macular degeneration.
So macular degeneration is extremely common, particularly in northern Minnesota. And it's basically, I like to describe it as a slow thinning out or dying out of the central part of the retina, the macula, which is where we see the most clear, and where when we're looking centrally, that's where it is affected. There's two main types: dry macular degeneration, wet macular degeneration. There's varying subtypes within those, but that's kind of what I like to talk to patients about. The dry macular degeneration tends to be about 90% of the patients who get it, with maybe 10% of the visual problems. Wet macular degeneration tends to be about 10% of patients with about 90% of the problems. So wet macular degeneration can cause some serious visual issues for patients, and so it's one of those that we monitor pretty closely. Gets worse as patients age. It's more in our elderly population above the age of 60 to 70 years old. So we see quite a bit of it. There are some exciting treatments out there now for both forms of dry and wet that we can talk about later, but that's kind of the gist of macular degeneration.
I think just another backgrounder, and then we should probably focus, but Todd, maybe a little bit about glaucoma. I was thinking about it as you were running through the iris there anyway, and if you just chat a little bit about it.
Oh, sure, yeah, and we can jump back to the model. I think it's helpful in explaining glaucoma, but the biggest thing to take home about glaucoma is this damage to the nerve in the back of the eye. Often related to higher pressures within the eye, but not always. The most common form of glaucoma in our country is open-angle glaucoma, and I think to explain this, it's helpful to look at the eye again, at the model. So, one thing I didn't mention in my original discussion of the anatomy of the eye is where fluid is made within the eye. The eye constantly makes fluid; it's how it keeps itself pressurized. That fluid is made back here in the back of the eye, but it's not where the fluid drains. The fluid actually has to travel around the lens and then out through the pupil, and then it has to drain in this little angle right here. So I just removed the cornea. So the cornea was right there. The fluid's going to drain between the cornea and the iris. In open-angle glaucoma, that drain doesn't work quite as well as it should. And so the pressure can build up within the eye, and then that elevated pressure can damage the nerve in the back of the eye. So that's one form of glaucoma. Another form of glaucoma is where that drainage angle is slightly narrow, or in some instances, it's closed off completely. And that again causes an increase in pressure, which damages the nerve in the eye. All of our treatments for glaucoma revolve around lowering the pressure, and that can be with drops or laser, or if the glaucoma is very severe, with surgery in the operating room. Glaucoma can be sneaky. It can impact your vision long before you ever notice it. Which is why it's important to have regular visits with your eye doctor, where we can do specialized tests, to detect glaucoma early and treat it.
Joe, we were talking earlier a little bit about sometimes when you're doing cataract surgery, you can treat the glaucoma at that time also.
There is a set of surgical procedures called micro-incisional glaucoma surgery that at least initially have been kind of done with in conjunction with cataract surgery. One is called an eye stent, which is two little tiny tubes, if you will, that are implanted in the eye. It's actually the smallest implantable device that's currently on the market, and those tubes basically bypass the trabecular meshwork, which is the drainage angle of the eye, and serve to modestly lower the intraocular pressure. So, and there are other types of implants and various techniques for this, which kind of shows you that there's not one that's above and beyond the rest. It's a very much evolving area in ophthalmology.
Charlie, what causes glaring in vision, especially at night? And I think if I suspect we're going to say cataracts or other things.
I
Probably.
was going to say there's a lot of things.
Yeah, so you can do that, and then I think we need to look at cataracts a little bit too. So.
Yeah, so I think obviously that is kind of a loaded question when we go in and see patients, and we see patients having glaring at night and they're 75 years old. Yeah, we're going to think about cataracts first. So that is primarily one of the things that as the lens slowly gets more and more dense, more and more cloudy, it's going to cause glare. It's going to cause streaking, star bursting off lights, particularly at night, especially when the pupil dilates a little bit. It catches all the light traveling through all parts of that lens, and it's going to start scattering, and that's what causes the glare. It can be a little tricky, though, especially in younger patients when we have glare and halos. Because it could be caused by dry eyes, it could be caused by abnormalities in the cornea, uncorrected astigmatism or uncorrected refractive error. So there's a lot of times where we'll get consults for cataracts, and we've got these other things that might be playing part of the role in our evaluation, and it's kind of on us to help identify those and talk with those about the patient.
Joe, I'm going to swing back to you because we kind of talked about this a little bit earlier. A friend had cataract surgery. She was able to change her vision after her surgery with a type of treatment. Is this a new technology?
That might be talking about the light adjustable lens. That would be one example of a technology lens that is out there that you can kind of lock, or you can adjust the refractive error. So one of the things with cataract surgery is, in a sense, it's like refractive surgery. In other words, when we change out the lens of your eye, we can put any power of lens in there that we want to, and usually, in many cases anyway, people would like to get rid of their glasses, but that's not an exact science, and so if you end up, you put this lens in there and it ends up being not exactly perfect what you wanted, this technology that's known as the light adjustable lens can be adjusted with a laser. And then once you get the, or I shouldn't say laser, it's light.
UV light.
UV light. It's actually Todd knows more about this than I do because he puts them in. And then once you're happy with the refractive error, then there's another light that you shine in there that locks in the refraction, and then theoretically it's good for forever. So another kind of amazing technology that's out there.
Very good. Todd, this is a question for you, and what is the background in cataract surgery and military background? Is there something between cataract surgery and military? I'm not aware of anything.
I'm not either.
Okay, so much for that. Seeing a lot of questions on dry eyes and watering eyes. Charlie, you're up.
Great. This is something that, is there a specific question or just talk
Okay,
about
we'll bring one
All
in.
right.
My eyes won't stop watering. Is there something wrong with either my tear ducts, or is there something else I can do to stop it? I don't have an age. I don't have anything more than that.
Maybe, yeah. So we get to have this conversation all the time, at least in my clinic. I'm assuming you guys do too. But tearing, especially if you have irritation, dry eye is extremely common up here. We see it all the time. We've got cold, dry, arid winters that really play a role here. And there's other things that can cause tearing too. So dry eyes is predominantly, what I see in my clinic as the driving factor for tearing and watering. You can have other things. You can have, if the eyelid is not approximated to the eye appropriately, the tears can't access the drainage system. And so that might be playing a role in the tears. If the drainage system is clogged, that might be playing a role in tearing. So when patients come into our office and we see that, there's a multitude of different things that it could be, and it's kind of on us again to kind of break down, find out what the problem is. Dry eyes is extremely common, and a lot of times, since it's less challenging to treat it in the sense of it's not invasive, we'll probably start treating that first and see where things go.
Other comments?
Yeah, I think it's either a reflex problem like dry eye, as as Charlie mentioned, or sometimes the tears aren't leaving the eye like they should, so a drainage problem. Yeah.
So, Todd, because you're the expert on the eye, this is a really good question. I think we need to put it out there. How do I protect my eyes while watching the solar eclipse?
Oh, yeah, so solar eclipse coming in April. So you do not want to look directly at the solar eclipse. The safest way to watch it is indirectly. The method that I've seen is to make a pinhole in a piece of paper and shine the eclipse through the paper with the sun behind you. There are special glasses that you can wear. Your sunglasses will not work. Do not wear your sunglasses and look at an eclipse. There is a list I saw on our Academy website, the American Academy of Ophthalmology, of approved eyewear that you can wear to watch the eclipse.
Yeah, great. It's really very important. Because there's a diabetic question that's been just sitting here. I think we're going to end up doing is jumping around a little bit because there's a lot of questions coming in. Thank you. I'm a diabetic. Should I be concerned about my eyes and vision? And Joe, jump in.
Well, the short answer is yes. Diabetes is a disease that has many complications as it goes along. And one of the organs that can be profoundly affected by diabetes is the retina, which is, of course, the visual organ of the eye, in the back of the eye, as Dr. Britton pointed out. And diabetes is a disease of the blood vessels, and that's another one of those sneaky diseases as well that in the early phases doesn't have symptoms and yet may require treatment in order to prevent severe vision loss in the early phases. So usually people who have diabetes, they're recommended, in type 2 diabetics, they're usually recommended to start seeing their eye doctor annually for a dilated fundus exam. Usually people with type 1, especially if they have younger onset, it would be within the first 5 years of being diagnosed. So it's very, very important to get that screen. Most diabetics that I see do not have diabetic retinopathy, and those that do, it's mild and they don't need treatment, but there are plenty of people that we see who could have done a lot better if they'd come in earlier. And the other piece of that is the best thing you can do. I'll give you two best things you can do. One is to keep as tight a control of your blood sugar as you can, and two, if you're a smoker, you got to quit smoking. Smoking and diabetes is like matches and dynamite. Not a good combination.
Smoking's not good for anything in the
No.
body. Are there any non-surgical treatments for cataracts? I don't know of any.
Not that I'm aware of. So
Nothing-
there's a
nothing
lot
effective.
of promises out there, but realistically, the cataracts are going to slowly develop. Everybody gets cataracts. If you live long enough and you start to have visual symptoms, you'll need to have the cataracts removed. And so that's kind of the conversation I have with my patients is.
So how do you determine
eventually-
when to take them out?
I look at three things. I look at what their vision is. So, usually on average, patients who are best corrected to 20/30, 20/40, we're starting to think about it. I look at the lens, make sure that the lens matches what I'm seeing with the patient's vision. The third and most important thing is what are their symptoms, and are those symptoms bad enough for the patient to want to undergo the risk of surgery? So there are patients out there who, even though they're 20/20 and we can correct them down, if they're having significant enough symptoms, and like Joe had mentioned earlier, if it's affecting their daily life where they're not doing the things that they want to, like driving at night, or they're having to wear sunglasses all the time because the brightness, those are reasons to consider surgery.
Todd, a person with macular degeneration and glaucoma had a complete loss of vision when looking in the direction of the sun. Should they be concerned?
Yes.
Yeah, I think that's the answer. Do you want to talk about, we kind of talked about macular degeneration a little bit. Anything more you want to add on that while you're there with it?
No, I think
Pretty
the
got it.
importance with macular degeneration is just routine eye care, seeing your eye doctor, as scheduled, and then I think there's a lot to be said for monitoring at home, as well. I think a lot of us tend to be dominant with one eye, and it's not until we cover that dominant eye that we may notice changes in the other eye. So I often instruct my patients, we used to give out tests, for macular degeneration for patients to look at every day. A lot of patients would lose the test, and it's hard to keep track of these things. So, but just testing your vision while looking at something up close is a good way to test for changes. What we're testing there is often the progression, specifically from the dry form of macular degeneration to the wet form. The reason this is important is they are treated differently. The wet form, is treated with injections of medications, and the dry form is primarily prevention with diet, vitamins, not smoking.
Can I go back? So that patient,
Yeah, jump in.
the person who called, sorry, it sounded like they had a specific question on whether or not they should be worried about looking into the sun.
Yep.
And so obviously what Todd said is that, if you're having vision changes, come and see one of us or your primary care provider. But one of the things that with these chronic diseases, and what I talk to patients is, you now have an optic nerve that's not functioning like it was when you're 20. You have a retina that's not functioning like you were when you're 20. So if you all of a sudden are looking at a really bright light, you're flooding all those retina cells with bright light, and they're trying to recycle and send that signal back as fast as they can, but they don't work as quick. And so it's that is slowed down, and so that's why they're getting that dull image. So it might just be as simple as, well, I'm now flooding the system there, and I gotta let it catch up a little bit, but if it's a new change, like Todd said, we should see. So I wouldn't be panicking that vision that permanent vision loss is imminent, and it might just be part of the disease process, but you should have one of us check it out.
Joe, we talked a little bit earlier about floaters. So there's always a floater question. What is the current treatment recommended for dry eyes and floaters? It's kind of a double up.
All right. Well, I mean, those are two separate issues that they're common enough that they often occur together, but they're not necessarily related or caused by one. One's not caused by the other. Dry eyes, the foundation of treatments is lubrication, and the other piece of treating dry eyes that's important is we have oil glands in our eyelids called meibomian glands, and making sure that oil is healthy. So, I mean, warm compresses is kind of the very, very basic treatment of that. So that's kind of the initial treatments of dry eyes, and there are many, many others. The dry eye industry is a multi-billion-dollar industry in this country, so it's extremely common, and it's a thing that causes a great deal of suffering. And then vitreous floaters are suspended opacities in the jelly in the back of the eye that's between the lens and the retina, and those opacities tend to accumulate with age. There is an aging process by which the vitreous becomes separated from the retina, and that's typically when floaters classically show up, although there's different various types of floaters. If a lot of times people will get floaters, and within a month or two they seem to drift into a place where they don't notice them as much. So typically in the acute phase we don't treat floaters, although if someone gets brand new floaters, they should come in and get looked at, because there's a tiny chance that you could have a retinal tear that would only be detectable by an eye doctor on a careful dilated exam. So, if someone acutely gets floaters, they need to be seen within, I'd say, 48 hours or so. And then if people have chronic floaters that last longer than 6 months and they're bothered by them, there are a couple of treatments out there. One is called laser vitreolysis, which is a kind of a tissue disrupting, or it's actually really vaporizing those opacities. And that can be a long, slow process. It's good for relatively focal floaters. And then there's a small subset of people with floaters chronically that have, almost like a giant galaxy of them rather than a tiny little constellation. And those people can go on to a more major surgery called vitrectomy surgery, where the jelly of the eye is just removed along with all the floaters, and then that's replaced with saline, salt water.
We'll continue on this just a little bit. The question is this person has tearing of the retina in the past. Does this come back, and should this person be concerned? So Todd, Thoughts on that one?
So I guess without knowing further history, it would be dependent on whether it's been treated. I'm assuming this patient has had it treated with either laser or, sometimes we'll freeze those areas. Certainly there's a risk that they could develop a retinal tear again. I would advise a patient like this, if they should ever experience any new floaters, any new flashing lights, that they should be seen right away by their eye care doctor.
Then I agree. Iritis. Want to talk about iritis a little bit?
Sure. So iritis, anything in the medical language that has itis at the end of it means inflammation. So when we talk about iritis, it's specifically inflammation of the iris. It's kind of synonymous with anterior uveitis. So uvea is the iris, the ciliary body, the choroid of the eye, which is a little bit, we're talking about the like very small anatomy in those cases. But basically you have inflammation inside the eye, and there can be a large number of things that can cause that. It can cause redness, pain, light sensitivity, and if not treated appropriately, can lead to other things like secondary glaucomas and vision loss. And so these can run the gamut from it's very, very mild, easily treated, to patients having kind of a more long, drawn-out treatment with potential for vision loss, or even systemic issues. So a lot of patients who present with iritis can be presenting as either an initial sign or symptom of a systemic inflammatory disorder, or as a secondary symptom of a systemic inflammatory disorder. So a lot of those patients we end up testing and looking for other disease processes.
We're learning a lot more about inflammation in the body and disease.
Yes.
It just really is coming along. Ocular migraine. Any one of you want to? Joe, Todd, go ahead.
Yeah, I can cover it. I have ocular migraines myself, and at first they are very scary. So our textbook ocular migraine is typically a shining, shimmering, geometric shape that you see in your vision, often lasts for approximately 20 minutes. Sometimes you will get a light headache, after you notice the visual symptoms. But once it is gone, and you do not have any other symptoms. They can be brought on by stress, lack of sleep, dehydration. But the important thing to realize about ocular migraines is that they are harmless, provided when they go away, and you don't have any other symptoms.
Anything more to add? Joe, this gentleman's brother had cataract surgery and developed an infection in his eye and lost his vision. How common are complications from cataract surgery?
Generally speaking, complications of cataract surgery are not common. The infection rate is somewhere in the neighborhood of between 1 in 1,000, 1 in 2,000 of bacterial infection inside the eye, but that can be a devastating complication. Other big complications similar to that are retinal detachment is also about a 1 in 1,000 chance after cataract surgery. It's rare in this day and age with small incision cataract surgery, but you can get bleeding underneath the retina, which can be also a devastating complication of cataract surgery. Yes, there are a very small number of people that actually go blind from cataract surgery, which Dr. Ahrens had alluded to earlier, excuse me, is a very strong part of the reason why we don't do cataract surgery just when cataracts show up. We want the benefits of doing the surgery in terms of increased vision to outweigh the risks, small though they may be.
Charlie, the prognosis for someone with myopic eyes, so those big deep eyes, as well as cataracts. Can the cataracts be removed to improve the vision? And what can be done? Some people are very myopic and have a lot of difficulties.
So I guess
and you can all jump in on this.
So I guess I suspect that the question means a younger patient who's myopic without visually significant cataracts is kind of how I'm going to address that.
Yeah, that's all we can do.
Yeah, so I can kind of address that. So there are patients with high myopia who want.
Let's go back. What
Sorry.
is myopia?
Sorry, myopia is basically nearsightedness. So I'm nearsighted. Without my glasses on, I can see from me to you just fine. If I try to look at the tree off in the distance, it's blurry, I got to put my glasses on. So that's nearsightedness, and that's what the majority, and even I would argue that more and more percentage of our population is gearing towards, as we're more on our devices, more into books, and those types of ventures. But so if patients have high myopia, the shape of the eye is a little bit longer, you can have problems with your vision. And so if you're looking for a refractive change, you can do PRK, LASIK, there are surgical corrections, there's contacts, glasses, the wide gamut. There are a certain population of patients who have high myopia who don't qualify for LASIK or refractive surgery. And so those patients might be good candidates for what we would consider refractive or clear lens exchange, where we basically go and we do the cataract surgery as the refractive surgical choice, not because it's visually significant in the sense that they're having problems, but because they're doing it for the refractive outcome of not needing glasses.
Todd, switching horses again. Eyelid surgery. Talk about eyelid surgery and why we do it.
Yeah, so we do eyelid surgery for a number of reasons. Upper eyelid surgery is primarily done if the upper eyelid is drooping, coming down, or if there's excess skin overhanging the eyelid, and it's impacting vision. And not just impacting vision, but interfering with the patient's daily activities. Eyelid surgery in this case, involves removing that skin or raising the upper eyelid, or both. With regards to the lower eyelids, oftentimes it involves tightening the lower eyelid. Over time, as we age, sometimes the eyelids start to come down, sometimes even turn out, which can be quite uncomfortable and bothersome, leads to a lot of trouble with dry eyes. In these instances, we'll tighten the lower eyelid, put it back into a normal position to treat the symptoms.
I've seen a lot of elders too where the lids turn in,
Mm-hmm.
and so some more. That's very helpful in that area too. So let's put a preventive hat on a little bit. One of the questions is prevention of glaucoma, cataracts, macular degenerations. Tips for protecting eyes. Any one of you?
I guess I can go. So basically, I tell patients the biggest thing you can do is eat a good, healthy diet. Eat your green leafy vegetables, basically the fruits and vegetables. If you smoke, quit. If you don't smoke, don't start. Obviously, doing the routine eye exams will help so that we can identify, like we've talked about earlier. If we can identify, glaucoma, macular degeneration early enough in the disease, we have a pretty darn good chance of presenting significant vision loss later on. A lot of times vitamins are always asked, and what I talk to patients, if you're eating a good healthy diet and you don't have any eye issues at all, keep eating a good healthy diet. That's the best thing you can do. If you don't, just a regular multivitamin would be a good idea. There's a lot of discussion about the specific eye vitamins for macular degeneration. I tend not to put patients on it unless if they meet the certain criteria based on the studies.
I agree, and I like to say that for macular degeneration in particular, it's kind of handy because the risk factors that are modifiable parallel those very closely of those for heart disease. So smoking, hypertension, high cholesterol, and body mass index are all independent risk factors for macular degeneration. You can't do very much about your age or your family history, which are the other risk factors for macular degeneration. Glaucoma, not very much preventive you can do, although there's some thought that kind of staying fit and healthy and kind of maintaining cardiovascular health might be somewhat protective against glaucoma. That's more theoretical, never been proven, and same with cataracts. I don't know of any really strong recommendations in terms of preventing cataracts other than don't live long enough, which we don't recommend.
Can you have cataract? Can you be put to sleep for cataract surgery? Now, usually you kind of put us out, having been there, but
So you can. It would take a special case because the risk of having general anesthesia is much higher than IV sedation. So the large majority of what we do is IV sedation, and some people need a little more, some people need a little bit less. In the right patient, in the right situation, general anesthesia may be required or can be done.
Where does the fluid come from or travel to when a person cries or has lacrimation? Tears. Where does that come from? I don't think we covered that. We talked about it. But Todd?
Sure. So, primary areas are lacrimal gland, which is located underneath the upper eyelid. This often comes into play with reflex tearing, which we talked about with dry eye symptoms. That's why counterintuitively we get tearing when our eyes dry out. It's kind of our eye's last-ditch effort to try to moisturize itself when it's dry.
What causes floaters after cataract surgery? And I know you do some laser work sometimes afterwards, so whoever wants it.
Yeah,
Joe, you're up.
I'll talk about that. One theory I have is about floaters becoming more prominent after cataract surgery is now all of a sudden patients can see them a lot better. I know in many cases those floaters, I can document, or I can look back through my notes and I can say, okay, I saw this person's floaters before I took their cataract out. I took them out and all of a sudden they really notice them. So that's at least some of it. But I think there probably is a subset of people in whom that natural aging process that I talked about whereby the vitreous and the retina become separated from each other. I think there's a certain percentage of people in whom that process happens at or around the time of cataract surgery.
Quick answer, is there a difference between eye drops with and without preservatives?
Yes. One has preservatives and one doesn't. But, if people are, some people, not to be trite, but some people are sensitive to preservatives. For most people that are not taking eye drops more than about 4 times a day, they'll do just fine with preserved eye drops.
Very good. Thank you all. Great job. I want to thank our panelists, Dr. Charlie Ahrens, Dr. Todd Britton, Dr. Joe Morehouse, and our medical student volunteers, Henry Larson, Connor McCullochek, and Joe Miller. This is our final program for the season. Our thanks to all the physicians, mental health specialists, phone volunteers, and others who have been with us throughout this season of Doctors on Call. We hope that you've enjoyed these programs. I also want to thank Linda Liskowitz for all of the work that she's put in to make sure this happens. Thank you and good night.